Hi friends, in today's video we're going to be talking about myocardial infarction, and if you like this video make sure to give it a thumbs up and subscribe to my channel. I come out with new content every week to help support pre-nursing students, nursing students, and nurses throughout their nursing journey. Alright, let's get into it. So what is myocardial infarction? It's also known as an MI or a heart attack, and it is a coronary occlusion as myocardial ischemia causes an acute coronary syndrome that can result in myocardial death. In an MI, an area of the myocardium is permanently destroyed because plaque rupture and subsequent thrombosis formation results in complete occlusion of the artery. The acute coronary syndrome includes unstable angina, non-ST segmented elevation MI, and ST segmented elevation MI. So the pathophysiology includes unstable angina, where there is a reduction of blood flow in the coronary arteries, usually due to a rupture of the atherosclerotic plaque, but the artery is not completely occluded. There is also development of infarction as the cells are deprived of oxygen, ischemia develops, cellular injury occurs, and lack of oxygen leads to infarction or death of the cells. This is just a chart that I really like about the pathophysiology of an MI. So you guys can screenshot this and print it out. I just think it's a really nice overview of everything going on, the mechanisms of action, the signs, symptoms, and lab findings that you will see with an MI. And so this is just a really helpful chart. We can see that an MI leads to tissue necrosis and local myocardial inflammation, which leads to inflammatory cytokines that spread systemically. And this is what's going to increase the C-reactive protein and also stimulate neutrophils and monocytes migration towards an area of inflammation. So it may also increase the white blood cell count. Then if we look at the next one, dead or damaged cardiac myocytes release inner contents into the blood. So 2 to 4 hours after an MI, you're going to see troponin proteins released into the blood, and that's why usually if people think somebody has an MI, they check troponin levels. You'll see an increase of cardiac troponins, and this is a sensitive and the most specific serum marker for myocardial necrosis, and this will lead to relatively slower clearance from circulation, and serum troponin levels usually will normalize after 14 days. You'll also see 3 to 8 hours after an MI, creatinine kinase, MB isozymes, and release into the blood. So again, we're going to see an increase of those markers, and it has a relatively faster clearance in circulation, so it will normalize in about 3 days. And lastly, we'll see tissue ischemia, which disrupts the normal cardiac electrical conduction, which you can detect on an ECG, and you'll see ischemia of subendocardial myocardium, which can lead to ST segmented depression, which if ischemia progresses to tissue infarction, and pathological Q waves will be seen. And then same with acute transmural myocardial ischemia will lead to ST segmented elevation, but it still has the same outcome. So just a nice chart you guys can use. All right, so what are the causes of an MI? So we have a vasospasm, which is the sudden constriction or narrowing of the coronary artery. There's a decreased oxygen supply from acute blood loss, anemia, or low blood pressure, and an increased demand for oxygen. This can have a rapid heart rate, ingestion of cocaine, or thyrotoxosis, which causes an increase in the demand for oxygen. All right, so this is just a picture of an MI, and there's different types of MIs. So you can see the little vessels on the heart. What happens is they get blocked or occluded, or they vasospasm, and it restricts the blood flow to the cells in that area. So you have a type 1, a plaque rupture with thrombos, a type 2, vasospasm or endothelial dysfunction, or a fixed atheroscleral and supply-demand imbalance, or a supply-demand imbalance alone. That just shows some different types. All right, so for these patients, the clinical manifestations we're going to see are chest pain. This is usually what everyone associates with having a heart attack, persistent and crushing substernal pain that may radiate to the left arm, jaw, neck, or shoulder blades. It's usually described as a heavy squeezing or crushing and can persist for 12 hours or more. They also may complain of shortness of breath because of the increased oxygen demand and decrease in supply of oxygen. This can lead to a shortness of breath. There's also an ingestion. They may present as a result of the stimulation of the sympathetic nervous system. You can see some tachycardia or tachypnea to compensate for the decreased oxygen supply. The heart rate and respiratory rate may speed up. You may see a catecholamine response. So this could be such as coolness in extremities, perspiration, anxiety, and restlessness. You also may see a fever, which usually occurs at the onset of the MI, but a low-grade temperature elevation may develop during the next few days. So how can we prevent MIs? So exercise is a good preventative measure. Exercising at least 3 times a week can lower cholesterol levels that may cause vasoconstriction of the blood vessels. Also, a balanced diet, eating fruit, vegetables, meat, and fish should be incorporated in the patient's daily diet to ensure that he or she gets the right amount of nutrients they need. And smoking cessation. So nicotine causes vasoconstriction, which can increase the pressure of the blood and result in an MI. So assessment and diagnostic findings. So first, we're going to want to take a patient history. We're going to want to get a history of the presenting symptoms, a history of previous cardiac or other illnesses, and a family history of heart disease. We can also look at an ECG. We can look for ST elevation, which would signify ischemia. We can look at peaked upright or inverted T waves, which would indicate injury. And we can look at the development of Q waves, which signify prolonged ischemia or necrosis. We can also look at cardiac enzymes or isoenzymes like CPK-NB, which elevates within 4 to 8 hours, peaks at 12 to 20 hours, and returns to normal 48 to 72 hours. We can look at the LDH, so elevates 8 to 24 hours, peaks in 72 to 144 hours, and may take as long as 14 days to return to normal. And LDH1 greater than the LDH2 helps confirm diagnosis of an MI if not detected in the acute phase. We can also look at troponin and troponin 1 and troponin T. So levels are usually elevated 4 to 6 hours after an MI. It peaks at 14 to 18 hours and returns to baseline over 6 to 7 days. These enzymes have increased specificity for necrosis and are therefore useful to diagnose MIs, especially when the MB-CPK may be elevated related to musculoskeletal trauma, because that can elevate that as well. Myoglobin, this is a heme protein of a small molecular weight that is more rapidly released from damaged muscle tissue with an elevation within 2 hours after an acute MI, and peak levels occur between 3 to 15 hours. Electrolyte imbalances of sodium and potassium can alter conduction and compromise contractility. White blood cells usually appear on the second day after an MI because of the inflammatory process. We can also look at ESR, which rises on the second or third day after an MI. We can look at chemical profiles. These can be abnormal depending on the acute or chronic abnormal organ function or perfusion. We can also look at ABGs, which will indicate hypoxia or acute chronic lung disease processes. We can look at lipids, where elevations may reflect atherosclerosis as a result of coronary narrowing or spasm. You can also use a chest x-ray. which can be normal or show an enlarged cardiac shadows suggestive of heart failure or ventricular aneurysm. We can look at a two-dimensional echocardiogram, which may be done to determine the dimensions of the chambers, septal ventricular wall motion, ejection fraction, and valve configuration. We can look at nuclear imaging studies. These can evaluate myocardial blood flow and status of myocardial cells. We can look at cardiac blood imaging, which evaluates specific and general ventricular performance, regional wall motion, and ejection fraction. We can also look at something called technictum, which accumulates in ischemic cells, outline necrotic areas. We can look at a coronary angiograph, which visualizes the narrowing or occlusions in the coronary arteries and is usually done in conjunction with measurements of chamber pressures and assessments of left ventricular function, also known as the ejection fraction. The procedure is usually done in the acute phase of an MI unless an angioplasty or emergency heart surgery is imminent. We can look at a digital subtraction angiography, which is a technique used to visualize the status of the arterial bypass grafts and to detect peripheral artery disease. We can look at an MRI, which will allow visualization of blood flow, cardiac chambers, and intraventricular septum, valves, vascular lesions, plaque formations, and areas of necrosis and blood clots. And we can use an exercise stress test, which will determine cardiovascular response to activity, often done in conjunction with thallium imaging in the recovery phase. So a lot of different tests we can do. So pharmacological therapy, we would administer morphine in an IV bolus, which is used for an MI to reduce pain and anxiety. We can also use an ACE inhibitor to prevent the conversion of angiotensin 1 to angiotensin 2 to decrease blood pressure and for the kidneys to secrete sodium and fluid and decrease the oxygen demand on the heart. And we can use thrombolytics, which will dissolve the thrombus in the coronary artery, allowing blood to flow and minimizing the size of the infarction and preserve ventricular function. This is a procedure, emergent percutaneous coronary intervention, is used to open occluded arteries and promote reperfusion to the area that has been deprived of oxygen. It's also called a PCI, and it may be indicated in patients with unstable angina and a non-STEMI for patients who are at a higher risk due to persistent ischemia. All right, so our nursing assessment and diagnostic findings will include assessing for chest pain not relieved by rest or medication, monitor vital signs, especially blood pressure and heart rate, assess for the presence of shortness of breath, dyspnea, tachypnea, and crackles, assess for nausea and vomiting, assess for decreased urinary output, assess the history of the illness, perform a precise and complete physical assessment to detect complications and changes in the patient's status, and assess IV sites frequently. Different diagnoses we can use for these patients, and there's a lot. These are just some examples. Ineffective cardiac tissue perfusion related to reduced coronary blood flow, risk for ineffective peripheral tissue perfusion related to decreased cardiac output from left ventricular dysfunction, and deficient knowledge related to post-MI self-care. So different planning and goals we can use for these patients. Again, these are just some examples. So we want to relief of the pain and getting rid of the ischemic signs and symptoms, prevent myocardial damage, absence of respiratory dysfunction, maintain or attainment of adequate tissue perfusion, reduce anxiety, absence of or early detection of complications, chest pain absent or controlled, heart rate rhythm sufficient to sustain adequate cardiac output and tissue perfusion, achievement of activity levels sufficient for basic self-care, and anxiety reduced or managed. So our nursing priorities are going to be to relieve the pain and anxiety, reduce the myocardial workload, prevent and detect and assist in the treatment of life-threatening dysrhythmias or complications, and promote cardiac health and self-care. So different nursing interventions we can use for this patient population include administering oxygen along with medication therapy to assist with relief of symptoms, encourage bed rest with back elevated to help decrease chest discomfort and dyspnea, encourage change of positioning frequently to help keep fluids from pooling in the bases of the lungs, check skin temperature and peripheral pulses frequently to monitor tissue perfusion, provide information in an honest and supportive manner, and monitor the patient closely for changes in cardiac rate and rhythm, heart sounds, blood pressure, chest pain, respiratory status, urinary output, changes of skin color, and laboratory values. And our evaluations are going to be dependent on our patient outcomes, but here are some examples. There's an absence of chest pain or ischemic signs and symptoms. Myocardial damage is prevented. Absence of respiratory dysfunction. Adequate tissue perfusion maintained. Anxiety is reduced. And our discharge and home care should include education. We want to teach the patient about heart-healthy living. We want to have a home care nurse assist the patient with scheduling and keeping up with follow-up appointments and adhere to prescribed cardiac rehabilitation management. We want to do follow-up monitoring, so they may need reminders of their follow-up monitoring, including laboratory value tests and ECGs, as well as general health screens. And adherence, the nurse should also monitor the patient for adherence to dietary restriction and prescribed medications. And our documentation guidelines should include individual findings, our vital signs, cardiac rhythm, presence of any dysrhythmias, a plan of care and those involved in planning, a teaching plan, responses to the interventions, teaching, and actions performed, and attainment or progress towards desired outcomes, and modifications to the plan of care. All right, so that is the discussion on MI. If you guys want to check out, I have a lot of free resources below. I also have an NCLEX study guide. So if you like this video, make sure to give it a thumbs up and subscribe to my channel, and I'll see you guys next time. Bye.